I'm LNJ, Vice President of Marketing with Intelerad Medical Systems. And today I'm talking to Kip McMillan, Chief Executive Officer of Diversified Radiology of Colorado in Denver. Kip, can you tell us more about the history of Diversified Radiology?
Be happy to. We track our original group back to 1926, which was a Dr. Bob Allen. I'm not sure exactly what radiology looked like in 1926. So we've been a company about 85 years. In the mid-90s, three local groups really merged together to become what is now Diversified Radiology in the Denver metro area. And we've grown a little bit since then, acquiring new hospitals. But that's where it all started.
Good. Can you tell me what, if any, what are the specific needs for radiology reading and reporting here in the Denver area?
Yeah, we staff 12 hospitals and a host of multi-specialty clinics or non-hospital-based imaging. So that's kind of our staffing model. I think it's pretty traditional for large medical groups. We have about 55 radiologists. Very high subspecialty reading model, which is pretty much the standard in large metropolitan areas. I think if there's anything unique about Denver to some other areas is our population density is a little less. Certainly Denver has a lot of people, but a lot of the population is spread out geographically. So we find for us, teleradiology practice of radiology becomes critical because we're pretty far apart.
What would you say is your geographical coverage?
We pretty much cover most of the state. We're as far north as Greeley, which is pretty close to the Wyoming state line. As far east as Sterling, which is getting pretty close to Kansas, Nebraska area. As far south as Durango, which is the far southwest corner of the state. So it's pretty diverse.
What led you to the decision to work with Intelerad for your medical imaging in the first place?
Sure. You know, our need as a practice was we knew the PACS, all our hospitals had started adopting or flirting with the idea of PACS, and this was a number of years ago. Our practice had some imaging centers, but at that time our need wasn't so much the storage of images in a PACS system, although it would have been nice. We really were very interested in coming up with a product that would allow us to have a single work list for our physicians. Most of the vendors we had spoken to about that wanted to sell us PACS, and because we purchased PACS, we'd get a single work list product. I don't think at the time we were looking there really was a electronic work list product standalone available. Understandable, there probably wasn't that many applications for such a product, so not a lot of development had been done. I think as more hospitals got PACS systems and groups started to experience the challenges of a single radiologist in any given day having to deal with multiple disparate PACS systems, suddenly it became more common challenge in the industry, and now more of the vendors started turning an eye toward maybe there's a niche or an opportunity here for building a product that would aid the radiology companies. And so that was kind of our introduction. A little flirting with PACS, a lot of disappointment in that we were going to financially invest in a resource we really weren't going to use much of. And then looking for, over time, a vendor who was willing to commit to specifically what we needed. And hopefully pricing it for just what we needed.
You are using now the Intelerad distributed radiology solution. Can you tell me how this has changed the way you work?
Yes. Probably a little background on what our objectives as an organization are. Diversified has always been very proactive in creating a corporate-controlled reading environment for our doctors. And have invested resources to do that. We have a lot of hospitals. 12 hospitals is a lot of hospitals for a group our size. we early in the game decided that we wanted to own all our reading stations in hospitals. This was a little bit of a political battle. I think while hospitals were very agreeable to it being our capital purchase, they did recognize it as a control issue of who owns the reading station in our facility. That was important to us because we wanted to have the flexibility to have our physicians read studies that perhaps didn't originate in that facility. We knew to do that, even in the very early days of teleradiology, we needed to be able to load software on our reading stations, which again, if it was owned by the hospital, would be difficult. Not impossible, but certainly challenging. So we kind of started there in the very early years of teleradiology by owning all our reading stations. Our goal looking to the future has been for a while, we feel that every radiologist looking to the future is going to have to be able to read from anywhere within our system of studies, so that the convenience or expectation that a physician could set at a hospital and all their volume on any given day would come just from that facility probably is unrealistic looking forward. So we, again, there's a financial cost to doing it, but we envision at some point that every study in our system will flow through the electronic work list, which for us is Intelerad. And even if you're sitting at hospital A and all your volume for that day came from hospital A, it wouldn't be a direct read on the hospital's PACS system, but in fact would be populated through our reading platform. So we want a single reading platform and a single voice recognition system for all our doctors every day, and we want it to be the same one.
Do you have an idea of how much time this represents for, like in terms of reading time?
Sure. Let me speak to that.
Yeah, that's good.
So it's not simply having an electronic work list for us or having Intelerad for the tool. What's important to understand is you can't do it without the tool, but there's a lot of factors that play into building the efficiency. For us, though, we know that having a single reading environment with a single voice recognition solution at a minimum adds 20% efficiency to the doctor's day. By doing away with dialing into multiple systems, multiple different dictation systems, heaven forbid having to log back on to approve because the system you're dialing into doesn't have self-edit capability, it is a minimum of a 20% saving. And there's the potential for it to go up from there based on how you design what your physicians are going to be reading during the day.
Right. Also, one of the benefits that was mentioned around IntelliOne and then asking questions around IntelliOne was the ability to direct the studies to the appropriate specialist. You said you were reading for like multiple hospitals and I guess images from different modalities.
You know, we set this up before we even dreamed that we'd find a product that would do it for us. And we did it with, I think as most things evolve, we did it with human resources, what we refer to as air traffic control. And they would take and we'd determine individually, oh, this study goes to this reader. And that worked well in the early days when there was a small handful of subspecialists and you know, appropriate volumes for them. As the industry develops and as more and more studies become subspecialty mandated and as more and more of our staff of physicians become subspecialists, it, you know, as you would expect, becomes extremely difficult to do that with human intervention on every case. It slows the process down and it introduces the opportunity for error. So for us, one of the requirements of any electronic work list was that we could set up crosswalk tables to say under what scenarios of data available to us can we then determine who the study should be assigned to appropriately. And that all happens automatically. A little bit of oversight, certainly a lot of setup, but that becomes automatic and that becomes critical to make sure that the program's going to work.
I guess ultimately having a solution like IntelliOne, like improving the efficiency and access to images for the physicians also contributes to patient care. What's your perspective on that?
I think, you know, one of the challenges of any medical delivery system, and certainly in the United States, is you have so many specialists in hospitals and clinics and pathology and so many pieces of the puzzle for your health record and your health care. You know, it would be naive to assume that in all of that, sometimes access to that information is either delayed or missed or problematic at best. What IntelliOne allows us to do, because it is such a highly integratable product, that's one of its cornerstones of being a benefit to us, is we can integrate with medical records and hospital systems and risks. It's just inherently beneficial to the patient. Not frequently being a patient myself, but I can imagine the frustration and the challenge in trying to track down all your medical records and make sure your care provider has that information. This allows us as a radiology group to say, well, this is at least one that you won't have to track down, because we can easily supply the report or the images back to your caregiver or future caregiver without a lot of additional effort or primary effort on the part of the patient. So I think it's just an easier system for the patient of availability. I think it's faster service. I think it gives even the most rural of environments certainly access to a high-level subspecialty interpretation of their exam that they might not have enjoyed prior to the ability to have access to a Telerad sort of reader. So I think while it might be harder if you asked a patient, hey, what do you think the benefit is, they probably don't realize what the benefit is. But there are benefits there for the patient.
Do you think also, like we didn't talk about the fact that IntelliOne was allowing you to pull all the priors from all the different places they may be stored in at the time of the interpretation? Do you think that's also something that's contributing to a better diagnostic maybe for the patients?
Well, it certainly is. You know, even historically, groups and radiologists always tried to get that information if we knew it existed, and sometimes it existed and we didn't know. But even historically, we would say, well, we need all the prior films to be able to give proper interpretation. So that service was there. But you can imagine the amount of time it took to contact the office and get, even if you could get electronically, it was a special process to provide it. In a lot of cases, there was no electronic, so now you had to wait until the hard copy images were forwarded. And it was kind of a hodgepodge in some cases. They may have 3 prior exams from 3 locations. One would come electronic, one would come burned on a disc, and one would be a film jacket. Made it, the turnaround times were, certainly in today's world, totally unacceptable. We're talking measuring in days and weeks as opposed to hours. So there's a huge benefit, at least in the access to rapid, timely interpretation of a study. And usually the more important the interpretation with priors, the more important a rapid interpretation becomes. So yeah, I think it has specific medical benefit to the patients.
You recently introduced night reading services for your hospital customers. What was the rationale behind that, and why now? You've been in business for a very long time, as you said as an introduction.
Well, and we provided internal Nighthawk services for a long time as a practice. You know, it has kind of shifted. The bigger the group grew, the more hospitals we covered, the more the need for reads at night grew. And to a point about 7 years ago, we had one of our physicians staffing all night long, doing what we refer to as a preliminary read, meaning I'm going to give you the answer you're looking for, but I'm not going to read everything on the scan. We recognized that there was a lot of shortcomings in this. The group had started to evolve towards subspecialty reading, and a single radiologist at night can't provide subspecialty reading. And it seemed a little disingenuous to say we provide subspecialty reads for our patients, unless, of course, you get sick at night. So we didn't like that. Anytime you're pulling a daytime physician out of rotation to read at night, there's a lot of consequences to that. It destroys the continuity for the hospital wherever they would have been reading during the day. It puts that subspecialist reading at night in a position where they may be reading studies that, while they're certainly capable, it's not what they do as a routine, and therefore there might be a different or better interpretation if it was done by a subspecialist. Turnarounds were difficult to keep pace with the expectations on turnarounds. So the group decided at that time, you know, we really ought to partner with a service that does this professionally, that could provide deeper coverage, better turnaround, and greater subspecialty. So we did. And we did this in consultation with our hospitals. Obviously, they had to agree and participate in establishing the service. And that was fine for a while. As time passed and as demands increased and expectations likewise became more demanding, we realized about 6 months ago that truthfully preliminary reads would no longer meet the needs or demands of our customers, that they really wanted a full final read even if it was 2 in the morning. You know, we didn't contemporaneously read, historically any group contemporaneously read plain x-ray at night. The thought being most physicians at night, being non-radiologists, were capable of at least reviewing a plain film and then waiting the next day for a radiologist's interpretation. Turns out the demand has changed. They really do want a radiologist reading that, even if it's 2 in the morning. So that's why we brought it in-house. If I was being totally honest, we did it a little bit for our own good. That doesn't suggest that the demand wasn't real and the need wasn't real. It was. But what we recognize as a practice is this. If we're ever going to get the hospitals to embrace the idea that they should let us use our own reading environment and our own voice recognition, and they should be excited about integrating that with their hospital systems, we had to make them as passionate about it as we were. One way to accomplish that was to suggest that if they wanted us to provide final reads in the middle of the night for their hospital, then they had to let us use our reading environment and our voice recognition system. So it kind of served as the fulcrum we were really looking for to get hospitals much more willing and interested in working on this interface of our systems with their systems. And that was one of our motivations for bringing our own overnight. As it happens, it worked for us there. Those hospitals that have converted to our in-house service have been enthusiastic beyond my expectations for the service that we're providing. So everyone has benefited.
As a solution provider, what would you say makes Intelerad different from other vendors you may have experienced?
Well, we've experienced a lot of vendors, not necessarily just the teleradiology. What we liked and what we look for in all of our vendors. In our experience, all vendors' products have a life cycle where sometimes their brand new release, they'll be at the top of the product cycle and have all the bells and whistles. And then there's times when they haven't released and somebody else has leapfrogged them with some new feature or something. What we're looking for is we want them to be cutting edge, certainly. We want to make sure they have a strong product development environment. But mostly what we're looking for is a willingness and a sense of partnership and cooperation in meeting our company's needs. And that's certainly one of the strong motivations we had in choosing Intelerad, was we really felt comfortable with the company and the feeling that, hey, they're going to work with us and they take seriously how we view the market and what our needs are as an organization.